Welcome to the Frontier AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Thanks so much, everyone, for joining us this week. We have a really exciting and special session. We're going to have a talk from Dr. Christina Mara, and then she is going to help us discuss two complicated neurologic cases before we discuss a tough resistance case. You probably remember Dr. Mara is a professor of neurology here and an adjunct professor in medicine and infectious disease. She is our neuro-ID expert for our Madison Clinic patients, and we are extremely happy to have her back talking about a tough issue in CNS Escape. Christina, thanks so much for doing this, and I'll turn it over to you.
Well, thanks for the introduction. So Brian asked me to talk about central nervous system escape in HIV. When we think about CNS escape, we use this definition, loss of control of brain HIV infection in a patient on effective antiretroviral therapy. But as I put this together, I realized that there are a lot of things we should think about and maybe not take for granted. One of which is that we're not going around biopsying people's brains to make this diagnosis. We're making the diagnosis based on spinal fluid. So we should call it CSF escape, and probably not all CSF escape is the same. So I'll begin with a patient. I took this from the recent case report. 50-year-old HIV-infected man on stable combination antiretroviral therapy for 9 years. No pretreatment resistance mutations in plasma, on tenofovir, emtricitabine, and boosted anizanavir. During this entire 9-year period, he had undetectable plasma HIV RNA, but he presented with 2 months of gait ataxia, headache, and memory loss. This is a picture they gave of his brain MR, so it's a T2 weighted scan. The ventricles are white because the fluid is white, and you can see the sort of fluffy white change in his deep white matter. It's pretty non-specific, but it's been described in people with advanced HIV encephalitis, HIV encephalopathy. He's, again, undetectable in plasma. His CD4 was almost 800, but his CSF was very abnormal. Had 75 white cells, a protein of 99, and 1,184 copies per mil of HIV RNA in his CSF. And again, that's much above what he had in his plasma. He had the M184 and K65R mutations, and his neuropsychological testing was abnormal. He was also having trouble with his activities of daily living, so based on the neuropsych testing and his difficulties with everyday life, he was diagnosed with minor neurocognitive disorder, which is a form of HIV-associated neurocognitive disease or disorder like minor dementia. He was treated with a change in his combination antiretroviral therapy regimen, so switched to zidovudine, lamivudine, boosted darunavir, and raltegravir, and over the next few months had improvement in his clinical status to the point that he didn't have any trouble with activities of daily living, although he still performed abnormally on his neuropsychological testing. So keep that in mind as we go through this. So I think we stop here and I come back to the issues I brought up in the beginning. There's really 3 things we need to think about here. So first of all, this diagnosis of CNS escape, which he got a diagnosis of, is based on spinal fluid, not brain. We don't go around biopsying people's brains. The CNS, or the brain, is not the same as the CSF, and all CNS escape, which from here on out I'm going to call CSF escape, is not the same. And this is just a cartoon of a sagittal section of a brain to remind you that the choroid plexus within the ventricular system makes the spinal fluid. It floats out and around down the cord and around the brain, is absorbed into the arachnoid villi, and then into the superior sagittal sinus, a big vein. And then the whole thing starts over again, so it's constantly circulating. It may or may not reflect what's going on in brain, but it isn't brain. It's what the brain is floating in, and it really doesn't provide much. The CSF keeps your brain from crashing into your head when you go no, 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 but it isn't really feeding the brain or really providing much value otherwise. So what's the source of CSF HIV RNA? And a lot of what I'm going to talk about today is taken from this really nice review article written by 3 groups of experts in the field. So if you're interested, I would encourage you to take a peek at it. So source of HIV RNA. Early in infection, it's the CSF virus is derived from blood. And it's really just trafficking of CD4 positive T cells and monocytes that are infected with R5 and T-tropic virus. And they set up an infection in the meninges, so the covering of the brain. You get CSF pleocytosis, so elevated white cells. But what you have is what people call non-compartmentalized or equilibrated virus. What you see in the CSF reflects what you see in the blood. And if you can control the peripheral virus, you can control the CSF virus. Contrast that with what we think happens later in infection, and this is a little bit hypothetical, but based on some okay data, that the virus is still R5 tropic, but becomes tropic for macrophages and monocytes, infects the brain microglia, which are resident macrophage cells, macrophages that come in and monocytes that come in. And at that point, we think about the infection being compartmentalized. So what we're seeing in CSF is reflecting what's happening in brain. It's not reflecting what's coming from the blood. And if you want to control that virus, you have to control the brain virus. So it's a sort of a different deal. So early, what we see in CSF is what we see in blood. And if you can control the blood, you can control the CSF virus. Later in disease, what you see in CSF probably more reflects what you're seeing in brain. You're going to need to treat that virus to control that CSF virus. So is that clear? And this is a cartoon I took from Ron Swanstrom's group, trying to sort of show you that in a picture. So what you have is, here's the blood compartment on the bottom, the CSF compartment in the middle, and the brain compartment at the top. So here we are at the beginning. We have virus in blood, and he means these to be T cells, but I don't think it needs to be that specific, but that's what the circles are, supposed to be T cells. So early on, blood virus goes into CSF. Now notice that there is virus in brain, and actually the brain is seeded really early in infection. There's a horrible case report of a person who got a tagged red cell study in the 80s, looking for a source of bleeding, and got the wrong person's blood. So got an HIV-infected person's blood, subsequently died a few days, I think 8 days later, of not from HIV, but from their underlying disease. And they were able to show pathologically that person's brain was infected with HIV. So the brain's infected, but it's controlled. And what you see in CSF is what you see in blood. As time goes on, you can get an inflammatory response with pleocytosis. But again, what you see in blood is what you see in CSF. Brain's not doing much. As time goes on and immunocompromise sets in, the brain virus can start amplifying. This is an example of clonal amplification. So the same virus amplifies in brain, and you see that in CSF. And then as time goes on, brain infection progresses as people lose immunocompetence. And again, what you see in CSF reflects what you see in brain. So here we're compartmentalized, here we're equilibrated, we're not compartmentalized. And I think, as I've already said twice, we don't go around biopsying people's brains, but I really think that the preponderance of evidence supports this model. So going back to the issue of CSF HIV RNA and CART, it turns out that systemic CART is largely effective in controlling CSF HIV, at least early on. So these are examples of real patient data taken again from that same paper. So on the y-axis, we have HIV RNA. On the x-axis, we have plasma versus CSF. So if you look at people who are off antiretroviral therapy, you'll see that CSF virus is usually a log lower in concentration than plasma virus. If you move to this panel C, again, HIV RNA on the y-axis, plasma versus CSF. Even in people on treatment who are failing, you can see that CSF virus is actually more like 2 logs lower now. So even ineffective therapy will somewhat treat CSF virus. This panel B is people who are on successful antiretrovirals, and you can see that both plasma and CSF are largely below the limit of detection. And then these are examples of escape. So plasma virus is lower than CSF virus, and we'll come back to that because that's our topic for today. So I wanted to remind you about drug penetration into the CNS and this issue of the CPE, or Central Nervous System Penetration Effectiveness Rank, which is something that's been developed by Scott Latender and others at UC San Diego, looking at how well drugs get into the CNS. And it's mostly based on CSF data, and then the chemical properties of drugs, and whether some drugs make people who have cognitive impairment get better. And a high number is more penetrant, a low number is more poorly penetrant. So the best drugs are ones we hardly use: zidovudine, nevirapine, boosted indinavir. The worst drug, tenofovir, we still use a lot. We don't really use much of these others. But then in the middle, you can see that there are drugs that we use every day. So abacavir, emtricitabine, efavirenz, boosted darunavir, maraviroc, raltegravir, and probably dolutegravir would go here if it were to be on this table. Pretty penetrant. Less penetrant, I don't know, I guess we use some etravirine, boosted atazanavir still. So you can take the number for each drug in a regimen, add it up, and you get the number for the regimen, which becomes important in my subsequent slides. So these are data taken from the Charter cohort. It's a big observational prospective study of about 1,500 people at 6 U.S. sites. So here we're looking at the proportion of charter participants who had detectable CSF viral load based and as a function of the CPE score of their regimen, so everything added together. And you can see that as the CPE of the regimen goes up, the proportion of people who have detectable CSF virus goes down. And it makes sense, and in fact, the CPE was based on these kind of data, so you would expect it to follow. You can also look at it in terms of dichotomizing your CPE. So again, proportion of patients with detectable CSF HIV RNA on the y-axis, and then dichotomizing by a CPE of 7 or less versus a CPE of greater than 7. And 7 is an average for the kind of regimens we use. About half of people who are at 7 or less have detectable CSF virus. About a third of people with higher CPEs have detectable CSF virus. So we've talked about two things that influence CSF HIV RNA. So one of them is plasma. CSF is usually lower than plasma. When plasma is above 1,000, you can usually detect in CSF. And we've talked about CPE. But I thought this was an interesting analysis looking at some other things, some of which make sense in determining whether you have detectable CSF virus and some of which don't. Again, taken from the Charter study. So this was a modeled probability of detectable CSF HIV RNA in about 1,000 Charter participants who were on combination antiretroviral therapy, although it wasn't entirely successful in all of them. And the things that ended up being significant in the model and contributing to this risk score, higher risk score, more likely to have detectable CSF HIV RNA, was CPE. So high CPE, middle CPE, low CPE. So you got more points if your CPE was low. Race made a difference. You got the lowest number of points if you were white, and the highest number of points if you were Hispanic, non-white Hispanic, or other races or ethnicities. If you were depressed, you were more likely, you had higher points, more likely to have detectable CSF virus. As you might expect, adherence made a difference. Highly adherent, you didn't get very many points. Low adherence, you did. Plasma HIV RNA we've already talked about. So if your plasma HIV RNA is high, you have you get a number of points. You have a much higher likelihood of having a detectable CSF virus. And then the number of months you were on therapy. Lots of months, not very many months. So some of these, I think, were things you would think would be pretty reasonable. I hadn't really thought about race and depression as being things that contributed to CSF HIV RNA, but they all do. They're independent, and even though you would think that CPE and plasma HIV RNA alone would be enough, each of these things significantly improved their model. And then they could actually give you a little graph of it. So probability of detectable CSF HIV RNA by their risk score. When you got around a risk score of 27 or so, about 50% of people were detectable in CSF. And for every 1 point increase in score, your odds of having detectable CSF HIV RNA went up 26%. So a lot of things contribute to whether CSF virus is detectable or not. So now I roll you back to the topic we were supposed to be discussing in the first place, which was CSF Escape. In this paper, they categorize it into 3 categories, which I think is okay, and it gives you a construct to think about it in, but I think there are some limitations that I'll try to point out. So symptomatic, asymptomatic, and secondary CSF escape. So the example I gave you was a good example of symptomatic escape, presumed to reflect virologic failure in CNS, characterized by newer progressive neurologic symptoms, virtually always accompanied by CSF, pleocytosis, or elevated white cells. And they point out that when the plasma is below 50, the CSF is typically above 50. When the plasma is detectable, the CSF typically is 2 times higher in terms of concentration. So example I gave you, an example of symptomatic CSF escape, which would meet our beginning definition of loss of control of virus in the central nervous system compartment. How do you treat it? Optimizing combination antiretroviral therapy, ideally based on a CSF resistance pattern, although some people would say you could just empirically increase the CPE of the regimen. But I would encourage you to try to get resistance mutations on CSF. So what's asymptomatic CSF escape? And these guys argue that it's CSF blips. Just like we have plasma blips, you can have CSF blips. And a lot of that's based on studies like this one. This is probably the largest one. 69 neurologically asymptomatic or neurologically stable HIV-infected people on combination antiretroviral therapy for more than 6 months with undetectable plasma. And 7 or 10% of them had detectable CSF HIV RNA. The copy number was low, with an interquartile range of 54 to 213. It wasn't related to the CPE of the regimen. It was related to longer duration of being treated, more treatment interruptions, and more plasma blips. But I think the thing that's really important to note about this study is that people who had these supposedly not meaningful CSF blips had higher CSF neopterin concentration. So neopterin is produced by monocytes and macrophages and probably reflects immune activation, which we think is probably not good. So I'm not entirely convinced that this is a totally benign thing. The same group does have a longitudinal study that showed that people who had these CSF blips didn't seem to get into trouble neurologically, but it's only been published as an abstract, never been published as a paper. And then finally, secondary CSF escape. So the person has superimposed CSF or CNS infection or inflammation, and this allows for an influx of vulnerable cells into the CSF that can become infected by what's in the brain. And it's been described in syphilis, Lyme disease, and zoster. But well, let me finish, and I'll tell you what my but is. Accompanied by pleocytosis, unclear significance, no change in CART recommended. But for these guys to get infected, it really means that the brain infection had to get activated. So I'm not entirely convinced that this is totally benign either, and I think that the jury is out. So I would encourage you not to just blow these other things off. But I think it gives you a construct and a way to think about it, and certainly gives you the idea that people who have symptomatic CSF escape really do need intervention. So to summarize, symptomatic CSF escape is probably uncommon, likely reflects loss of control of CNS virus, should be explored as a possibility in patients on therapy with new neurologic symptoms or signs, and most people, probably 80% of people, improve with optimization of their combination antiretrovirals, which ideally that optimization should be based on genotyping. Asymptomatic CSF escape may be common. It may just be blipping. The recommendation now is not to change CART. This is actually, Brian pointed out to me, is in the treatment guidelines. It's of unknown prognosis, but I think if it's associated with immune activation in the CNS, it might not be a good thing. And then secondary CSF escape, sort of an epiphenomenon of CSF or CNS infection or inflammation, CART change not recommended. I'll point out to you that the treatment guidelines lump these two together. They don't talk about them separately.